I wanted to discuss a really innovative and important trial, the COSTAR trial out of the CEDGE group of trials. And this focused on a population of people who inject drugs and patients maintained on opiate agonist treatment who were treated with the fixed dose combination of elbasvir in combination with grazopavir. So this is a very important population, the people who inject drugs that have been really excluded and neglected from other trials. And so this was the first phase 3 trial in the modern era of hepatitis C treatments that included people who were actively injecting drugs. All other of these trials excluded based on requiring a year of abstinence prior to initiation of treatment or enrollment in the trial. It's an important group in terms of hepatitis C because 60% of all patients who have hepatitis C have a history of injection drug use, and among new infections, more than 80% of new infections are related to active injection drug use. So it's really not a marginalized group, it's really the central group that we need to address. However, the barriers exist in treating this population, and first and foremost really is that many payers are not allowing this group of people to be treated. And they're citing the lack of data that because the phase 3 trials didn't include these patients, we don't know whether it works or not in terms of whether patients are going to be adherent or be able to complete treatment. What are the SVR rates and side effects? Are they in par with groups that aren't using drugs? In the United States, 6.6 million people have a history of injection drug use, and some of these people are actively using. There's nearly 300,000 patients maintained on methadone, and 80% of these patients, up to 80%, have hepatitis C. So it's a really important group in terms of burden of disease and understanding what to do. So the trial answered several fundamental questions. What are the rates of treatment completion in this population? What is the adherence rates? What is the SVR? And what's the side effect profile? As well as looking a little bit in reinfection. There's 300 subjects, and there was a randomized controlled trial where 200 subjects were randomized to the immediate treatment group and 100 to a delayed treatment group. The reason being that many people who are injecting drugs may have somatic complaints. We want to be able to separate these out from perhaps just baseline or using drugs or withdrawing from drugs from the actual adverse effects related to the medication. And so it was many people, as expected, because of the inclusion criteria, were using drugs. 60% were using recreational drugs throughout the trial, so the majority. And not just once, but stably throughout. Drugs including heroin, cocaine, amphetamines, and so forth. But despite this high rate of drug use, 97% were able to complete 12 weeks of treatment, and of that group, 96% were able to achieve SVR 12. Adherence was very high as measured by electronic diaries the patients used. In terms of the 80% adherence, 100% in the immediate treatment group achieved that 80%, and in terms of a 95% threshold, which is quite high, 97% achieved that threshold. And side effects were low, less than 20%. Main side effects being fatigue, headache, nausea, diarrhea, and really similar to what was seen in the other CEDGE portfolio, which enrolled patients who weren't using drugs. In terms of reinfection, there were 5 reinfections. Patients who had, at the time of virus was examined had a different genotype or subtype or strain compared to baseline, and this was confirmed by the population sequencing and phylogenetic analysis. So the implications are I think, very, very large. We now have the data to kind of show the payers that indeed this group of patients, opiate agonist treatment patients, in particular people that are using drugs, can achieve excellent outcomes on par with those who aren't using drugs. And this really mirrors the revisions from the ASLD IDSA guidelines, which now state that we cannot have restrictions based on a duration of abstinence, or we should not require even a urine tox screen in terms of pre-authorizations, because it's not evidence-based and it will add another barrier. It's onerous for both the provider and the patient. Lynn Taylor and colleagues conducted a very important study in the Annals of Internal Medicine, which demonstrated that 88% of the state Medicaids in the country have drug or alcohol criteria, with 50% excluding and 2/3 currently requiring urine tox screening. So we hope that we'll see immediate change in these policies and increase access. And again, it's not just for the individual patient, which is extraordinarily important, but it's also a public health benefit, because if you treat someone who has a potential for ongoing transmission, you can reduce transmission and reduce incident cases. And all over America, there's a new cohort of people who are injecting drugs, young adolescents, young adults, in suburban and rural settings, who are starting on oral pills or narcotics and then transitioning to heroin and contracting hepatitis C at high rates. So whereas originally we saw it in the birth cohort, which is still an important group, we're now seeing this uptick in young Americans who are unfortunately experiencing a second wave of this epidemic.